Good morning, dear friends. Thank you, Partha, for inviting me to this IC, which is always very well attended. Phakic IOLs, a lot of interest. I've been doing phakic IOLs from 2002, started with the Verisize, did the Verisize for 2 years. And from 2004, I shifted on to the ICL. And now it's almost 12 years, nearly 4,000 implants. And by and large, the safety is quite good and the results have been excellent. I'll show you a few of the challenging cases that I had, interesting cases. This one was cataract extraction with ICL in situ. This was a young patient. We did a hyperopic ICL and he developed a posterior subcapsular cataract. He had a hyperopia of almost 12 diopters and the lens requirement was almost 52 diopters. So there were different options whether to actually explant the ICL, put in a piggyback lens, or then what I decided is I'll try something innovative. So what I did is, keeping the ICL like that, I just lifted the proximal haptics and then went ahead, put in viscoelastic, and under the ICL I did a capsulorhexis through a clear cornea incision. I thought I would maintain this as a piggyback lens. So this is what I call phaco with ICL in situ. And this was a young hyperop. So my plan was to just remove the cataract and put a standard 22 diopter lens. And you can see there towards the end I'm using a forceps to complete the rhexis. You can actually, there is adequate space once you lift the proximal haptics. You can go in and do the rhexis. You do the hydrodissection. This is a young patient, so the nucleus is quite soft. It's a anterior subcapsular cataract. So I go in just with the IA probe. I don't use the phaco probe. And then I just aspirate this cataract and the nucleus. This is under the ICL. And there is viscoelastic between the ICL and the cornea, so it's quite safe. This patient, hyperop 12 diopters, was miserable. He had adequate ACD, so we put in an ICL. He was doing very well. 1.5 years after that, he developed a cataract, and he was a little disappointed that we may have to remove the ICL because he had paid quite a bit for the ICL. And this is cleaning up of the cortex. And you can see all along the ICL is there in its place. And this is only for hyperopia. And then I used a standard 22 diopter IOL. Of course, it's very difficult to predict the IOL power because the effective lens position of the IOL and the effective lens position of the ICL can change. So you can get some errors. That is injecting the lens into the capsular bag. So inject the lens, standard 22 diopter lens, into the capsular bag. Once it settles down in the bag, the proximal haptics are again tucked under the iris. Then you remove the viscoelastic. So this patient actually did quite well. He had a residual refraction of about 1.5, but he was still happy. And his burst corrected vision regained to what he had pre-op. And he was happy that his ICL is still there. So this is something interesting which we did. Of course, development in biometry, new nomograms can help this. But you can use the ICL as a piggyback lens. Here I've used it as a piggyback lens even without explanting it. So that is just a take-home message. That's the end of the procedure. There was one more re-rotation and exchange of ICL. This was a 40-year-old male, high astigmatism, unsuitable for LASIK, high refractive error, white to white. Okay, this was the post-op uncorrected vision 6.6. After 1 month, he complained of blurred vision. And left eye, the vision had dropped to 6/18, and he had, this is the kind of refraction he had, plus and minus. Pre-op, the white to white was 11.4, and on dilatation we found that there was a 70-degree rotation, so we had to reposition the lens. We repositioned it again after 15 days. He complained of blurring of vision. UBM, we did a UBM and then checked, and we had a very large sulcus. So this is the repositioning surgery. So you mark the 0, 1, and you can see that the lens has rotated quite a bit. So you go in through the side port after putting viscoelastic. You can rotate the lens. Again, it was supposed to be at like 15 degrees clockwise, and then it had rotated quite a bit, almost to 70 degrees. So I rotated it and placed it, and then I thought it would be successful. Checked, the position was quite good. Adjusted the final position, and then you have to just remove the viscoelastic and then hydrate. But then you can just look at what happens when I think I'm done now with the surgery. Re-rotation is fine. Position of the ICL is toric ICL is adequate, exact position. So I thought I can close. Again, rechecked. And then you can see I just irrigate the viscoelastic out. This is methyl cellulose. I'm irrigating it out. And then I think, okay, we are closed. So I'm hydrating. And then you can see the position here, the mark here. Again, recheck just to make sure that it's still in the right position. These are high myopic eyes with low scleral rigidity. So I find that the pressure is not adequately maintained. I want to hydrate a little more. I hydrate, and then you can see what happens. The lens has shifted. You can just watch it in slow motion. See how it shifts? So what happens is these myopic eyes, when they expand a little, the lens can shift. The sulcus to sulcus changes. So again, I repositioned it. Okay, did not pressurize the eye so much, but what I found is after 15 days, again this lens had moved and this patient came back with blurred vision. And then we did the UBM and we found that the sulcus to sulcus was quite large, much larger than the overall diameter of the lens. And so we had to exchange the lens for a bigger size. So this is something that you need to keep in mind. When you have an ICL rotation, then if the patient has not had any trauma to the eye or not rubbed the eye, the possibility is the sulcus to sulcus. You go back and check your measurements. Sometimes you may have taken the wrong measurements. You remeasure the white to white. You see if you have ordered the right lens. If all that is done properly, then it is best to go back and check with the UBM and see. Sometimes you have an anatomical abnormality, the sulcus to sulcus is larger, and then you may have to exchange the lens for a larger size. This is just an ICL exchange, which I am showing you.
Sri Ganesh.
Again. Yeah, it's almost done. So what I want to show you is that I hold the lens near the optic. That's the thickest part of the lens. This is just a 2.8 mm incision. You just rotate the lens a little, and then you don't hold it at the edge because it can tear. You hold it at the, and then you wriggle it, side by side movement, and the whole lens comes out easily. So this is how you do that, and then you can inject the larger, bigger size ICL. I'll just show you the opening of the lens, and I think we are running short of time. Yeah. Just check the position and then finish.
Thank you very much.